But with axiography, look, it's only 19, 21. It's the lowest border. This is not a movement that we would prefer. And that means that we have to think why it happens like that. Let's compare ourselves. Let's take free. Remember, it's 40 degrees sagittal condyle inclination. And let's try to do that with our own means. So this is free. I'll go here. Actually, what I don't like this too much, but it's out. I don't want to repeat this slope. It's definitely not good for articulator. So with the wheel, I do the small adjustment until I will start to have like it has to be either convex or it has to be straight. It couldn't be concave or straight. It couldn't be convex. If you start your movement with a convex, it's a mistake, and you can't repeat it in articulator. Here is pretty good. Okay, let's see how much I have. Look, 40 and 40. You see?
Okay. No,
so my manual articulator settings was the same as artificial intelligence. The same you do with a Bennett angle. And also, let's see, I don't remember the Bennett angle there. So when we do the sagittal condyle inclination or horizontal condyle inclination, ACI, we discard the middle picture. We don't look at it. We look at the side pictures. And also, let's see. Look, if we want to use, remember Kemper plane was too inclined in our analysis. Let's see it. Look what happens here. That's why maybe Kemper plane is not the right plane for the work here. And let's see horizontal. It's closer to what we have according to the horizon. So that's why psychometric analysis is so important, because you think, okay, I work with Kemper, but maybe our patient is not good for Kemper plane. Maybe if we'll do that, we have to struggle with occlusion. And maybe his teeth would be flatter, I don't know. So let's go to settings again.
I think the facial bow of Cavill.
Oh, it's awful. It's the worst.
Yeah, and they give you only the Kemper plane.
Yes, as well as actually with Artex, you can work with Kemper plane also. Yeah. Yes. It is not bad, but when the thing is that we have to know when to adjust patient to the articulator or when to adjust articulator to the patient. Not all our patients have perfect anatomy, and not all our patients would undergo orthodontic surgery. So in a way, what we're looking for, we want to have something in our hands or in computer that will reflect what patient is in reality. That's what matters. Because who created Frankfurt plane? Actually, it was created by an anatomist. Now, who created Kemper plane? I guess it was Kemper. I hope so. Yes. So why? Because they needed some kind of references. For example, for the edentulous patients, only Kemper plane. Yes, because we know that in that case we can have balanced occlusion. Because when jaw will move to the right and to the left, we can keep contacts between the balancing teeth. That's the idea of stabilization of the lower denture. But we don't have to do that with a patient who has fixed prosthetics. We have to have very nice disocclusion. So let's go to the right side and let's see. Oh, where he moves. I'm not sure where he moves. Let's go back. Like here, you see canine. But what I don't like here, no, it's okay. There is no contact here. So it's usually enough to be a flush position of canine with canine. Don't go more for the Bennett angle. And let's see the restriction here. Okay. That's not the angle I want to repeat, yes? You see, I remember when I was talking that the right joint is problematic.
Yeah.
So for us, we are deciding right now the left joint. This is what's important for us. But look what happens with the right joint during this movement. It definitely has problems with movement. So okay, let's see what it will say to us. So 1 degree. Well, strange. Yes, we definitely thought.
33.
No. This is when we do
this one.
Bennett. We look
yeah.
at this. So it was to the right. So we look Bennett here. But we can use this number to set their canine guidance inclination. And actually, when we do horizontal condyle inclination, like we had 40, plus 10 degrees, it will be 50 degrees of incisal guidance. So we can set these angles if you want. It will be at least something. You don't have to be strict about it, but that's general rule. That incisal guidance has to be steeper 10 degrees than sagittal condyle inclination. In that case, you'll do the, I would say, front teeth protected occlusion. So when the patient will go forward, his teeth, posterior teeth, would definitely disocclude, 100%.
And all this data after that are inserted to exocad. So
yeah, you can use these settings for exocad if you
lab
want.
make everything under this protocol.
Yeah. So let's go again here and let's do for the left side. A little bit more. I don't like this. Definitely.
Why?
It's not canine guidance, it's lateral incisor guidance.
Yeah.
It looks like it, yes, but it's not. Actually, no. Let's see.
It's the premolar.
Premolar, yes.
Yeah.
So I want to. They're still out of the contact, but just a little bit restoration, and let's do it a little bit more.